This is actually a fairly quick section because we really don't have any medications that work consistently for this. So the class that we're going to touch upon is the selective serotonin reuptake inhibitors. And we're going to talk about their use in children and adolescents, since that's what you're focused on. Here are the data. This is an unpublished, double-blind, placebo-controlled trial of fluvoxamine, or Luvox, in pediatric ASD. 12 weeks of drug or placebo, 34 children and adolescents with autism, Asperger's, or NOS. We started at a low dose of fluvoxamine, 25 milligrams every other day, because we anticipated it might be somewhat activating. This is the mean final dose that we could get to. There were major problems with tolerability. And this was the response. 1 of 18 patients that received fluvoxamine responded, and nobody that got placebo. So very low. Prominent side effects, behavioral activation. This is a double-blind, placebo-controlled study of liquid fluoxetine in pediatric ASD. It's a crossover study where the patients received 8 weeks of drug or placebo, and then the other. 45 kids started. There's the final mean age. There's the mean IQ. Starting dose was 2.5 milligrams a day, and the final dose was about 10 milligrams a day. Fluoxetine better than placebo on the repetitive behavior rating scale. Only the compulsion scale was used. People that are nonverbal, you can't tell if they have obsessions or not. There was no difference between fluoxetine and placebo in adverse events in this particular study. This is the most recent and by far the largest study. Kids with PDDs with significant repetitive behavior, 12 weeks, started at 2.5, max dose of 20, mean dose here. No drug placebo difference on the CGI-I or the SciBox for PDDs. Again, we'll hear more adverse events with drug than placebo, behavioral activation largely. This is a study of fluoxetine that was sponsored by Autism Speaks. 14 weeks of drug or placebo. It's the largest published, somewhat published study in autism to date. They were chosen for repetitive behavior. No drug placebo difference. So just a few comments on repetitive behavior in ASD. It's currently one of the core diagnostic features of ASD. In DSM-5, it will now be one of only 2. Previously there were 3, but social and language are combined in DSM-5. In our opinion, these guys often do it to self-regulate their behavior. They're flapping and rocking and doing things in an effort to calm themselves down. So it's not necessarily a bad thing, just because we don't do it. We do other things to calm ourselves down. So you don't necessarily want to try to eliminate that because it seems unusual. You want to try to reduce it if it's highly interfering. And sometimes you have to educate parents that why they may be doing this, because they're often embarrassed by the behavior of their child and wanted to say, have them stop this. And you have to teach them that you don't want them to necessarily stop it, because they then may do something else to try to address their feelings of frustration or anxiety. I guess I'm saying this in part when I think of a family doc or a pediatrician seeing it and go, oh my gosh, what should we do to get rid of that? Particularly if the parents are pushing for it. So medications for sleep that we're going to talk about right here in this order. Starting with melatonin. There's a very nice review that I took a lot of this from our colleagues at Ohio State. 13 published controlled studies of melatonin for sleep disturbance in children with developmental disabilities, total sample of 424. Parallel groups and crossover designs, dosing from 1 to 10 milligrams. Melatonin better than placebo in all studies. Adverse events mild and similar to placebo. Trazodone, no controlled studies in children with sleep disturbance. So this is what I do. I start at a 50 milligram tablet, a half a tablet to 1 tablet at bedtime. Somewhat based on the age of the child, I'd say, or the severity of the sleep disturbance. You could always just say start at a half. Increase by this amount weekly until their sleep is better, or there are side effects, or I say reach a dose of 300 milligrams at bedtime. That would be a relatively unusual upper limit. You could probably knock that down if you wanted to. There aren't a lot of side effects. Sedation is a side effect. That's the goal of the treatment. Sometimes it can be cause a little bit of irritability and sleep disruption. And it's always important to talk about priapism, so a sustained erection, particularly because many of these people may not be able to talk and let someone know that they're experiencing it. So I've seen it once in my career, and it was a young, probably a 12 or 13-year-old boy. We wrote it up as a letter to the editor as an educational thing. It didn't progress to any kind of medical emergency at all. He didn't have to go to the ER, but it just makes the point. Anytime, you know this, but it's important to say it, you're treating someone that can't communicate side effects they're experiencing, you really need to think a couple times about what you're prescribing. And usually we don't, probably. Let's see. Clonidine, no controlled studies. So begin at 0.1 milligrams, a half or 1 tab, increase by that amount weekly to 0.2 or 0.3. One thing you'll hear about and you'll see is people that initially have a great response to falling asleep. Over time, they may develop tolerance and begin waking up in the middle of the night. You could then try giving a dose then, but you've still got disrupted sleep. So in a way, it's worth thinking about, but if you know you're likely to run into that, why do you want to start down that course? But it's listed, I think, 3rd here or something, so I must think something of it. Mirtazapine is a drug many of us don't think about often. Remeron, marketed for the treatment of depression. People kind of niched it for the elderly because it can cause sedation, but also increased appetite and weight gain. And you'll see I like this drug when we get to anxiety. Kids that are anxious often have difficulty falling asleep, so no controlled studies. But if you're down the line here, it comes in 15 milligram tablets. It also comes in a dissolvable sol tab that you can cut. I start at 3.75 milligrams at bedtime. So this is one of those where it sounds really low, but I feel pretty strongly about this based on experience. I go up by that amount every week. You can see significant increase in appetite and then weight gain, which may eliminate it from the parent perspective, or you may not. And sedation. Amitriptyline. You see me getting down here because there's a lot of kids that we see that simply don't improve with that entire range. And this is one that I've found to be quite helpful. You might say, well, what about other tricyclics? I just tend to use this a little bit more. It's used, in primary care medicine a lot for pain and sleep. So I'm familiar with it in prescribing it. Another one you could think about would be doxepin. It's kind of in the same realm as a sedating tricyclic. No controlled studies. Starting out again, quite low. Again, you could knock this down if you wanted to. There are blood levels available for this that you could check. can lower the seizure threshold. You could consider an EKG if you wanted to, blood level. Benadryl and benzos. 3 controlled studies of Benadryl in children with sleep disturbances. Results were mixed. No controlled studies of benzos in ASD with sleep disturbance. Both can cause paradoxical worsening. Benzos can contribute to cognitive impairment and dependence. So here's mood stabilizers being used to treat bipolar disorder in autism. No data. These are the medicines that I'm going to talk about. There's some data for the first 2 anyway. So this is buspirone, Buspar, FDA approved for the treatment of GAD, been around a long time. Prospective, open label, 8 weeks, 22 subjects, an age range of 6 to 16. The majority were inpatients, which is interesting. Only 4 subjects were on other medications, and the target symptoms: anxiety, irritability, or anxiety and irritability. This is a very good clinician in the Netherlands. In this study, the starting dose was 5 milligrams TID. That's much higher than I started, but that's what they used. Maximum dose was 45 milligrams. The maximum otherwise, I think FDA-wise, is 60. They reached this in 3 weeks, which would be very quick in my world. Here's the final mean dose. 9 subjects had a marked response, 7 a moderate. So I think that's 16 out of 22. Adverse events: some sedation, agitation, nausea, well tolerated. They followed the 16 responders for up to 12 months with an average of 5 months. Therapeutic benefits were sustained. 1 boy developed a dyskinesia after 10 months that resolved when the drug was discontinued. There is some D2 blockade with buspirone. So that's really the best and only systematic study of buspirone. Mirtazapine. This is a study that our group did long ago, and when we were beginning to use it to try to get a sense of it for anxiety, just giving it to lots of different people. Now, so one of the really key things here is that these patients were refractory to lots of other medicines, so it's a highly refractory group. Average treatment of 150 days. What's that, 5 months or something? 26 subjects, wide age range, mean age, 20 had intellectual disability, 17 were on other medicines. The mean number of prior adequate trials was 5, almost 6, with up to 10 in some cases, so pre-refractory. Starting dose was 7.5, that's half of a 15 milligram tablet. This is much quicker than I'm recommending currently as well. Weekly increases of that amount. Final dose was 30 with a maximum dose of 45. 35% were better in different areas because they weren't chosen for a specific target symptom, more just refractory symptoms. Adverse events: increased appetite, sedation, some irritability. There are no published controlled studies of any SSRI for treating anxiety in autism. So let me say a little bit about that. So most of us would agree that a lot of people with ASD have anxiety. We would almost all agree to that. The field is currently trying to figure out how to measure it. how to diagnose it and how to treat it. We really don't know any of those things. So you'll see people doing things like, we're going to do CBT for anxiety and ASD, and we're going to include people that have social anxiety and OCD. You see what I mean? So they're using anxiety disorder diagnoses to label symptoms that are part of autism in a way. Social impairment, you don't call it social phobia, it's part of autism. It's not OCD, it's repetitive behavior of autism. So it's hard when we try to apply other DSM-4 diagnoses to these guys because we don't know what it looks like in these guys, particularly if they're lower functioning. But we all agree there's a lot of anxiety, all right? So, but as we've been wrong before in a way with, well, this is just simple ADHD, give them a stimulant. This is OCD, give them an SSRI. We might not really know what we're doing here when we say it's anxiety.